All right. Hi, everybody. Welcome to our April Soap Fellow webinar. My name is Emily Naoum. I am the co-director of these webinars with Dr. Jamie Daly, who is not available today. And so I am also the speaker for today. So I'll give you a brief introduction for those of you who don't know me. I am a dual trained critical care anesthesiologist and obstetric anesthesiologist at Mass General Hospital, and I'm the fellowship director there. Um, I did my undergraduate and medical school at the University of Michigan. Go Blue. It's a great week to be a Wolverine. And I did my residency at Mass General, went back to Michigan to do both my ICU and obstetric anesthesia fellowships, and have been on staff here since 2020. I practice clinically in the ICU, on the labor floor, and in the main OR. I have research interests in critical care obstetrics as well as cardiovascular disease. And the focus of my research is mostly actually mechanical circulatory support in pregnancy, but I also love sepsis. And I think it's an awesome topic that we really need to be better at identifying and treating in our pregnant patients. So hopefully this is helpful to all of you. It should not be a full hour, so we should have plenty of time to chat and maybe even end early. So please feel free at any point. You can raise your hand while I'm talking. I might not see it, but um, well, we'll have plenty of time to chat afterwards. So, all right, I'll dive into it. This is maternal infection. Uh, we'll see if okay. I have no disclosures. So my talk today, what I want to talk about is I want you to all take away how common sepsis is in our patient population and why it's so hard to recognize. Um, Kind of the main points of managing sepsis in the OR, as well as on the labor floor and in the ICU. It really should be aggressively treated no matter where you are. So I'll talk a little bit about like where I think we should be managing these patients and future directions in maternal critical care. So we do know that the definition of sepsis has changed over the last few decades, and this is in the general population, and the current definition that we use is the sepsis 3 definition. This is life-threatening organ dysfunction caused by infection. For maternal sepsis, we typically refer to the definition from the WHO. This is closely aligned to the sepsis 3 definition, but there's the added association of this being during the peripartum period. So determining just how frequency sepsis occurs in pregnancy is kind of challenging because, as I mentioned, the definition of sepsis has changed over the last few decades. And depending on how people were identified to have sepsis in those studies, the rates look different. So having said that, our most recent contemporary studies suggest that sepsis occurs in 0.1% of deliveries in the United States, or about 1 in 10,000 deliveries. Although that may seem rare, if you look at studies of maternal ICU admissions, sepsis contributes to up to a quarter of ICU admissions, and those requirements actually appear to be increasing. So this is incredibly relevant for those of us who work in the labor floor, as well as those of us who work in the ICU. And beyond ICU admissions, sepsis contributes to a substantial chunk of severe maternal morbidity and mortality. Embrace UK, as you may know, is a collaborative that reports on maternal deaths and morbidity in the UK and Ireland, and it provides really great data in terms of trends in maternal complications. So this is from the 2023 report, and you can see that maternal mortality from infectious causes has not improved at all over the last decade. And this is despite the Surviving Sepsis campaign, which came out many years ago, and efforts to identify and treat sepsis more aggressively. So we're not getting better. This figure comes from the most recent 2024 Embrace report, and it shows sepsis is actually the 5th leading cause of maternal death between 2020 and 2022. And I'll point out here that the 4th leading cause of death is psychiatric disease. And that'll come up again toward the end of this talk because obviously experiencing morbidity related to sepsis can be traumatizing and contribute to subsequent psychiatric disease in our peripartum population. So it is relevant and important to consider how we manage these patients. So why is this important? Well, if you're thinking we're America, we're totally different than the UK, think again. Our data from the CDC demonstrates that sepsis was the 3rd leading cause of maternal death in 2020, and other epidemiologic studies have shown that this rate has been flat over the last decade, contributing to anywhere between 10 to 15% of maternal deaths. That's a lot. So what causes maternal sepsis? The most common cause differs between studies. And so it's often easier to think about this in terms of what pregnant women, so actively pregnant women, the primary source of sepsis is most likely or is most often described as pneumonia or urinary tract infection. And in postpartum patients, it's more likely to be GU or surgical site infections. Interestingly, in a third of cases, we never identify a pathogen. When they are identified, whether that's from wound cultures or blood cultures, the most commonly reported bacteria include E. coli, staph, strep A, and other gram-negative bacteria typically found in the GI tract. Group A strep is not the most prevalent bacterial pathogen, but it is particularly virulent. Important to know is viral infections or viruses that may result in more severe clinical sequelae in pregnant patients include hepatitis E, Ebola, influenza, varicella zoster, and it does seem most likely that SARS-CoV-2 or COVID-19 was more virulent in the pregnant population. So what are the risk factors? Well, obstetric risk factors have been identified in many studies. And if you look here, these are some of the sentinel sepsis studies listed on the left. All the things listed on this slide have been identified in 2 or more large studies. And important to highlight are multiple gestation, preterm delivery, induction of labor, surgical delivery, and postpartum hemorrhage. There are also medical and socioeconomic risk factors that have been identified. Again, these have all been identified in 2 or more studies. This includes anemia, chronic heart, liver, and kidney disease, as well as obesity, African American race, and public health insurance. So we know maternal sepsis is important and who's at risk, but how do we identify these patients? So in the general population, we have standard sepsis screening tools, and this would be SIRS, SOFA, and QSOFA. And in the most recent Surviving Sepsis campaign, the recommendations include hospitals should implement a sepsis performance improvement program and use sepsis screening tools in high-risk patients. So I want you to look at the parameters listed here and think about our patient population. Are these applicable in our patients? Normal physiologic changes of pregnancy, you can see the overlap in SIRS is quite high. It is normal and expected to have a PaCO2 less than 32. Heart rate is most certainly normal, could be in the 90s. And a white count up to 16,000 is normal in labor. So most pregnant women, it's very possible that they could have positive SIRS criteria and not have infection. That's hard. And so let's talk about how to apply these in our patients. Well, the reason we can't use these is that, of course, the physiologic changes of pregnancy mimic those of sepsis. You have vasodilatation, a hyperdynamic state. And there was actually a multi-center case control trial done by Melissa Bauer. In 2019, they found that the SIRS criteria was highly sensitive, but poorly specific in this population. And QSOFA, which I'll go back for a sec, or I'll try to go back. QSOFA was very poorly sensitive, but highly specific. And that may be, she has a really great discussion on this actually about why she thinks QSOFA was not very sensitive. Again, look at our values here. A systolic blood pressure less than 100 is certainly possible and can be impacted by the presence of neuraxial anesthesia. And altered mentation is a very late sign or symptom of sepsis. So we're really relying on tachypnea to trigger our evaluation or our concern. Respiratory rate documentation everywhere in the hospital, but especially on labor and delivery, has not been known to be particularly reliable, which may be why you could have women who were floridly septic who had respiratory rates documented between 18 and 20. When they arrived to the ICU, it's often clear that they could not have had a respiratory rate of 18 or 20 because their CO2 is 20, and they have to be tachypnic, blowing off the acidosis from their infection. So all of this is to say, these are not great in pregnant patients for a number of reasons. So we need to have other options. This is especially important because waiting for patients to develop telltale signs of infection like a fever can actually increase their risk of death. Delayed recognition of maternal sepsis has been associated with increased mortality with every single hour that passes without treatment. In this report of women who died from sepsis in the state of Michigan, less than 1 out of 5 were febrile on admission, and 25% of these women who died never had a fever. So it's so important that we recognize maternal sepsis does not equal fever, and fever doesn't mean isn't the necessary criteria to diagnose infection. Because of this, I think it's important to talk about specific scoring systems for this population. There are a number of warning systems, scoring systems, screening tools designed for this population. Some of these use multiple parameters, some have aggregated weighted scores, and not all of these are specifically developed for sepsis. And so for the sake of time and what I think you actually need to take away and care for these patients, I won't go into full detail, and I'll try to keep it succinct and highlight the ones that I think are important and relevant for us. If you remember one of these, it's the California Maternal Quality Care Collaborative, or CMQCC toolkit for sepsis. This is a really easy to apply screening tool with a conformational assessment. It's also a huge document with tons of information for OB providers, anesthesia providers, ICU, and nursing. And it's awesome if you have time to go through it. But the main document really goes through initial screening, confirmation, and management. So what I love about this is that it includes actions to pursue if your labs or bedside evaluation suggests that your patient's infected. And here, this is a little mix. So the new toolkit just came out in last fall, and this comes from the old toolkit. But you can see here, there's an initial screening step that takes into account the patient's vital signs, and these are appropriately adjusted for the normal physiologic changes in pregnancy. And then there's a subsequent confirmation step that uses labs and bedside exams. So if any of these initial screenings, sepsis screen values are abnormal, 2 or more are abnormal, it mandates that you perform a lab, get labs, and go look at that patient, look at their urine output, do a pulse ox, assess them. Importantly, it pushes you to assess the patient. A provider needs to assess that patient. Now, the CMQCC, as I said, did just redo this toolkit. And so this is from the new one in 2025. You can see they have pregnancy-adjusted cutoffs for end organ dysfunction, and these should trigger clinicians to pursue aggressive sepsis management. You don't need all of these labs to look bad. Just one should be enough. And I really think this is important because this is an objective table you can review with your colleagues and say, hey, it's not normal that this lady's SAT is 92% on room air. It's not normal that, she's not peeing. And it takes away, this is my opinion, your opinion. It's an objective document that has been created by the experts to really critically evaluate patients in the framework of sepsis. So put together, there's a flow chart that can be used by providers and teams to screen, confirm, and importantly, take action on patients who have sepsis. I have used this to guide objective discussions about patient vital signs and labs and actually give antibiotics and or get source control sooner and transfer the patient to the ICU. So the CMQCC was used as a sepsis screening tool in 2 large case control studies in antepartum, postpartum, and delivery admissions in 2023. So what they found is that in patients beyond 20 weeks, the CMQCC had the lowest false positive rate compared to other maternal early warning systems and the SIRS criteria. So if you want to get to know one of these really well to help your unit identify and treat sepsis faster, this is it. You can look here. So if your patient screens positive for infection, the next thing to do is a bedside evaluation. Think about other diagnoses for sure. But if you don't have one, you need to start antibiotics within an hour, give fluids, increase your monitoring, and evaluate labs. Now, it seems simple, but I will tell you, I have used this, printed this out, and used it with our colleagues to say, I understand you think this is normal, but it is not, and here's why. And I have actually had good success with that because it's not me saying, this is my judgment as a doctor and I don't trust yours. We are all here taking care of the patient, and here is a well-supported national tool, and we're all in this together. I think there's a lot of explaining away why the map is 55 for hours and hours. That is never normal. And this is a great way to come together and just use an external document to say, I think we need to look at this patient and think about sepsis. So this is the CMQCC. It is available free, and I really encourage you to look through this. They have toolkits for lots of things, morbidity and pregnancy, but I really love the sepsis one because I think this is an area we need to be so much better at. Now, the obstetric early warning score uses multiple variables. It's a graded scoring system to generate a score, and it's had good positive predictive value to differentiate between people who survive and don't survive sepsis. My criticism is when you are busy on the labor floor, I'm not calculating this score. And frankly, I think some of these things are developed so that we can then develop a system and write a paper, and this isn't a practical warning system, in my opinion. Meows, which is a great name, this modified early obstetric warning system. It's another score. It's aggregate weighted system. They have multiple variables. It has been shown to identify patients at risk of going to the ICU. I think it's a little bit simpler and easier to implement, but again, is really challenging on a busy night for me to pull up this graph and sort of look at it and think about it. It's not super clinically useful. So the maternal early warning criteria, it actually evolved as a single parameter evaluation from the last one, the MEOWS criteria, to improve specificity. It's easier to use, it's faster, it gives more frequent clinician notifications, which can be really valuable in identifying patients before they decompensate. This can also be easily integrated into the electronic medical record and then automated to flag abnormal vital signs. This is what we use here at MGH. It's integrated into Epic. Patients who trigger maternal early warning criteria get a little red bell on their Epic on the grease board, and that should prompt you not only it should prompt evaluation, but you can literally see it and say there's something up. Look in the vitals, assess the patient, and decide what that means. And this isn't specific for hemorrhage because, as you can see, there's also systolic blood pressure cutoffs that are meant to increase the time or decrease the time to response to hypertensive emergency, but it certainly will trigger patients who are decompensating from sepsis as well. So a large California health system looked at pre and post implementation of a maternal early warning tool that they used in nearly 120,000 deliveries. So this was a really cool study. What they found was that 2.3% of all patients screened positive, and more than 80% of the people who screened positive had physicians intervene within an hour. This tool uses different pathways for common morbid events. So sepsis isn't the only event that they treated with this, but and I'll show you that tool in a moment. But what they found was that physicians followed the recommendations in the pathways 83% of the time. And they noticed at the end of the study that there was a significant reduction in severe maternal morbidity comparing baseline to after implementation, which is actually really an incredible outcome. Earlier recognition translated to earlier management and better outcomes. So let's look at it. Sepsis was actually the most commonly screened pathway, and it contributed to 38% of ICU admissions. So what I hope you will see is that this is important, and even though it seems rare, it's actually not rare, and it contributes to a lot of maternal morbidity that I think is potentially avoidable. So this is the treatment algorithm. Sepsis is at the far left of the figure, and this standardized approach to management ensured that physicians were notified and that there was a systematic approach with labs, antibiotics, resuscitation, and ICU consult if needed. It takes away some of the hemming and hawing and says, this person is triggered, this is abnormal, we need to fluid resuscitate and start antibiotics. I don't care if there is not a fever. All right. So finally, there is the sepsis and obstetric score. I'll simply say it actually does do a decent job of predicting ICU admission in infected patients, but again, it isn't easy or straightforward to calculate, so I have yet to find it clinically useful. What it could help with is if you have someone who does seem infected, but their score is less than 6, that was shown to have a negative predictive value that was almost 99% that they'll be fine. They don't need ICU admission. So it's just not something I have found is easy or helpful to calculate in our patients, but it does exist. There have been a couple studies on it, and this is like someone's project, and that's great, but I just, again, don't think it is actually really clinically useful. So I know it's a dizzying slur of acronyms. I just want to say each of these do have their strengths, and to clarify, they're not all specific to identifying sepsis. O's, MEOWS, and maternal early warning criteria, as well as the SOS score, do a decent job of identifying which patients are sick. The MUTE actually takes it one more step to provide clinical algorithms for care, and MUTE was associated with a reduction in severe maternal morbidity. So using these is helpful. which is why none of these systems are perfect, but the use of any one of them is valuable to identify sick patients and manage them promptly to reduce morbidity and mortality. And you can see this comes from the Surviving Sepsis campaign. It is strongly recommended that hospital systems have an appropriate screening system for acutely ill high-risk patients. That includes our patients. These two studies showed that using these improves outcomes. Now, it doesn't matter whether patients are pregnant or postpartum. Again, this first large cohort study looked at the CMQCC as well as SIRS and the maternal early warning criteria and delivery admissions. They found that the CMQCC had the lowest false positive rate compared with SIRS and maternal early warning criteria. And the second study was a large case control study looking at sepsis versus non-sepsis. For early pregnancy and more than 3 days postpartum, SIRS had the highest C statistic, but for our patient population on the labor floor, meaning between 20 weeks gestation and the first 3 days postpartum, pregnancy-adjusted sepsis screening tools, including the CMQCC, had the highest C statistics and lowest false positive rates. So if I haven't made it clear, the CMQCC is a really valuable toolkit to use it as a lens looking at your patient to identify sepsis and treat it quickly. So we have lots of tools because we know our patients have physiology that can be hard to discern from sepsis. Vasodilatation with a slightly increased heart rate and a respiratory alkalosis are normal in pregnancy. And the literature has shown us that an elevated lactate can be normal in labor, up to 4. Up to 4. Pregnancy-specific warning systems do help identify patients at risk, and maintaining a high index of suspicion is critical. These patients actually can look quite well as they're developing septic shock, and our responsibility is to act early. I also cannot emphasize enough how important our perspective is as the main physician on the floor with ICU experience. All of our residencies, we do at least 3 months of ICU and possibly more, and we are very good at recognizing sick patients. Our colleagues, our obstetrics colleagues, do not have that same perspective, and it is actually, I think, our obligation to be the critical care consult on the labor floor and really help them to see what we see. So managing pregnant patients with sepsis is actually not that different than non-pregnant patients, and antibiotics is key. Antibiotics targeted to the suspected source of infection or broad-spectrum antibiotics should be given as soon as possible. Delayed administration has been associated with increased mortality, even with just 1 hour delay. And that's in the obstetric and general population. Most antibiotics can be given, and if you're concerned, you can consult your pharmacist or OB. Typically, we avoid streptomycin, tetracyclines, and fluoroquinolones, but those are not the most common antibiotics you'd give anyway. Resuscitation considerations in our population include, of course, the use of left uterine displacement after 20 weeks gestation, and I encourage you to use TTE or POCUS and assess fluid status, since the physical exam can be hard to interpret, especially patients who are preeclamptic. It can be really hard because they are intravascularly dry but floridly edematous. So I think POCUS is a great opportunity for POCUS to look and see if they will be fluid responsive. Now, source control in this population is a little unique in that GU infections like endometritis and chorioamnionitis may warrant expedited or surgical delivery. D&E and even hysterectomy may be indicated for complex obstetrical infections, and other methods of obtaining source control may be indicated. So patients who have UTIs or stones, obstructed stones, they may require nephrostomy tubes or stents and wound debridement, and these can and should be performed in ongoing pregnancy. And you may be asked as the obstetric anesthesiologist to provide your recommendations for management. So we're going to talk about anesthesia. Now, guiding our resuscitation to markers of end organ perfusion is, again, similar to non-pregnant patients. You want to monitor their mental status and their hemodynamics. Urine output can be affected by fetal positioning in the pelvis. However, I never brush off low urine output in these patients. And note that your baseline creatinine is reduced in a normal pregnancy. So if your creatinine is 1, it's a red flag. As I mentioned earlier, there was a systematic review of lactate levels, and it showed that up to 4 millimoles per liter can be normal in laboring patients, particularly if they're in the second stage of labor. A lactate of 10 is not just pushing. And even if it ends up being just pushing, it is not normal. And I say this because literally 5 days ago, one of my most I think the brightest MFM colleagues said to me, I just think we can't take that lactate of 10 and say it was infection. And to me, that's crazy. It is not normal. I don't care. It is not normal. And the patient obviously did have an infection. But it is, people will explain away all sorts of things. A lactate up to 4 is normal, and beyond that is not. So after appropriate fluid resuscitation, if your patient is persistently hypotensive, vasopressors are indicated to maintain a MAP of 65. They don't get a lower MAP goal because they have an epidural or because it's normal in pregnancy or because they run low. It's 65, period. As in non-pregnant patients, norepinephrine is the first line, and there are several studies demonstrated the use of peripheral norepinephrine in pregnant patients that show it is safe and it is the appropriate vasopressor for sepsis. The addition of vasopressin is indicated if the patient's on escalating doses of norepinephrine, and I'm asked this a lot, is this safe in pregnancy? Can it cause uterine contractions? I have found zero literature supporting this theoretical concern, and in fact, lots of studies describing the use of vasopressin for various indications. Lots of our cardiac patients with pulmonary hypertension benefit from vasopressin, and I have my own personal use of vasopressin and expert support from my senior gurus in obstetric critical care. Do not be afraid. The best thing for the baby is perfusion. Again, as in non-pregnant patients, the third line vasopressor is epinephrine. As you are resuscitating your patient, there is one unique and extremely helpful monitor we have in our patients, and that is the baby. The fetal heart tracings can provide valuable information regarding end organ perfusion, and late decelerations are a sign of uteroplacental insufficiency. Minimal variability, both of these can suggest fetal distress. Fetal tachycardia can also indicate maternal infection, and it should be investigated. This often precedes the fever, and so use your baby to, again, build your argument if you are struggling with getting a receptive obstetrician when you're concerned for your patient being infected. Now, forgive me if this is too basic for this audience, but for completeness sake, I'd like to address some warning signs in the fetal heart tracing. As you can see, the top image here shows minimal variability in the fetal heart tracing, and the bottom image shows late decels, and these occur after the uterine contraction. Again, this is a sign of hypoperfusion. It is considered non-reassuring, and these may all build your argument to say this woman is sick. So what could go wrong? All right. Let's say you do have a patient with active infection, and I'll give you a real clinical scenario I had a couple of years ago. We had a term patient. She presented with a UTI, and she had gram-negative bacteremia, and it was now in spontaneous labor on the floor, and she wanted an epidural. Do you want to do it? Well, this is an important question because we all know regional anesthesia is used in upward of 80% of US labors. This is our preferred anesthetic for cesarean delivery. It has myriad benefits, including avoiding the potentially difficult maternal airway, fetal exposure to systemic medications, improved maternal infant bonding and breastfeeding success, improved pain control, and a lower EBL. Having said that, there are some real concerns placing a regional anesthetic in a patient with systemic infection. Infection of the neuraxis is not a small deal, and an epidural abscess or meningitis can be devastating. Sepsis may be associated with coagulopathy and thrombocytopenia, and it can increase the risk of epidural hematoma, of course. And finally, patients who are septic may have a profound hypotensive response to your sympathectomy, even when they're adequately fluid resuscitated. So this is the question I am asked most frequently by my colleagues. Should we be concerned about seeding the epidural space and causing an abscess? So I will show you the literature, and hopefully you will find this reassuring. There are multiple studies that report on the incidence of CNS infections in OB patients who have received neuraxial. So this first study out of Canada looked at 3.8 million neuraxial procedures in all patients, not just OB. They found the overall risk of epidural abscess is between 7 to 13 per million procedures, and that's pretty rare. The next study is also from Canada. They looked at 2.7 million OB epidurals specifically, and they found the overall rate was lower than the general population, 6 cases and 2.7 million epidurals. Next, we have a US report using the national inpatient sample, 2.3 million labor epidurals with 0 cases of epidural abscess. And another older retrospective study of more than 500,000 epidural placements in UK obstetric patients. They did have 1 case of epidural abscess, but these are all comers. So all of these are just everybody. What about patients where we know they have an infection? So the best studies that I can find to address this are old, But the first is Goodman et al. They looked at 531 patients with known chorioamnionitis on placental pathology, most of whom had labor epidurals. 146 of the 531 had blood cultures drawn, and 13 of those were positive. Importantly, a quarter of the women who were febrile and 3/4 of the women who had a white count did not receive antibiotics prior to their neuraxial. So this is, I would say, fairly consistent with what happens on the labor floor. But what they found is that there were no epidural abscesses, even with many women, most women, not getting antibiotics prior to their placement. Now, Bader et al. Looked at 279 women, of which only 43 received antibiotics before getting neuraxial. And at least 3 of these women had positive blood cultures consistent with bacteremia. And those 3 did not have antibiotics. They did not show any evidence of epidural abscess. So obviously the sample size we have is very low, and it's lower than we would want it to be. Given the incidence of low epidural abscess overall, we would like a much bigger study, but I think these studies provide reassurance, especially in the case of chorioamnionitis, which is our most common obstetrical infection, that it is safe to proceed even if they do have an infection. So the concerns for hematogenous spread of infection, your bleeding risk, potential hemodynamic compromise are valid. Up-to-date labs should be available, and your antibiotics should be administered. And ideally, get them in 30 minutes to an hour before you place that neuraxial. Every effort should be made to ensure the patient has been sufficiently fluid resuscitated and is relatively euvolemic prior to placing that neuraxial. I think it's really important that you have an individualized evaluation of the risks and benefits of regional by the attending anesthesiologist, and that you talk about it with your patient. Depending on the patient's risk factors, the very unlikely potential for an epidural abscess may be preferred over the alternative of general. And, that's particularly important if the patient's obese or has other comorbidities that would further increase their risk for difficult airway or hypoxemia with induction. Undoubtedly, some patients are bacteremic during the administration of our neuraxial, given how frequently patients develop fever and infection during labor. And actually, there is a study in 1981 that found a 1% incidence of bacteremia in just a random sample of patients on the labor ward. And other studies have noted there's an incidence of bacteremia anywhere from 5 to 12% in patients who have chorio. So I do think that it's more common than we realize, and it's not to downplay the importance of getting antibiotics in. I cannot stress enough how important antibiotics are, but I don't think that we should be using an infection as an excuse not to place a neuraxial. And I hope that this is a group of, our fellows are not going to be that group, but I think you will ultimately be advocating for patients as the expert in OB anesthesia, and you can feel, I think you should feel empowered to advocate for neuraxial placement, especially if they've received antibiotics. So I'll share that my patient with gram-negative bacteremia had received broad-spectrum antibiotics an hour before they asked for the epidural. We talked to her about it, and we placed a labor epidural that she was incredibly grateful for. So there is data, unfortunately, to suggest that regional anesthesia in the setting of chorio may not be as reliable as in non-infected patients. And so this is a study that included 132 patients, 58 of which had clinically diagnosed chorio. And the study demonstrated a mix of regional approaches, including epidural, DPE, and CSE. Unfortunately, they found an association between chorioamnionitis and failed epidural conversion to cesarean anesthesia, even when they adjusted for confounding factors like prolonged labor. The theory behind this is that inflammatory mediators may contribute to increased labor pain, and there are attenuated effects of local anesthetic under that inflammation that may have an impact, and there may be increased metabolism of local anesthetics due to increased blood flow and fever. So even with your wonderful neuraxial placement, that epidural may fail. It doesn't mean you don't do it, though. But why am I pushing so hard for regional? Well, we know that general anesthesia carries a risk to obstetrical patients, higher than the non-pregnant patients. And the risk of a difficult airway is substantially higher. There's a real risk of aspiration. The physiologic changes of pregnancy contribute to rapid desaturation, and hypotension may be profound in the setting of vasodilatory shock. That baby may be hanging on by just a thread. An induction of general could worsen your fetal status. But if the most appropriate thing is a general anesthetic, there are important considerations. Of course, the risk of awareness is increased in obstetrical patients and those in emergent situations with hemodynamic instability. Patients with sepsis are at extremely high risk because they're all of these things. Prolonged labor and chorio are associated with an increased risk of atony and postpartum hemorrhage. Again, when you're choosing a vasopressor, as I mentioned before, norepinephrine is your first line agent, and it can be administered peripherally. Again, ensuring adequate volume resuscitation is imperative. And finally, anticipate bleeding and ensure adequate IV access. As an intensivist, I do have a low threshold to place an arterial line, but this can impact the dispo for the mother, and that leads me to the final leg of our talk. So where should these patients be managed? Let's say you have a pregnant patient you're managing with sepsis. Where should you be doing this? There are arguments for both sides. So benefits to sending the patients to the ICU include availability of ICU interventions like mechanical ventilation, mechanical circulatory support, CVVH. Very unstable patients or those who have rapidly evolving illness may be best served in an ICU. Other reasons that may be less compelling are those who have stable vasopressor requirements or the presence of an arterial line. And this is unique based on different institutions, but it is, you know, it is real and we have to think about it. Benefits of keeping somewhat sicker patients on the labor floor include proximity to providers who know how to manage these patients, as well as to the operating room. So especially if they're still pregnant. A stat surgical delivery in the ICU is almost never the best thing for the mom or the neonate. And fetal monitoring and interpretation is easier when the patient is co-located with the obstetrician team, on the same floor. ICU admission may also separate mother and baby, and that has major implications for maternal bonding, breastfeeding, and psychological morbidity. As I mentioned earlier, psychiatric disease is a leading cause of maternal mortality, and it's not to be taken lightly. How best to manage these patients is a particular interest of mine, and I believe that the direction of the future is to have our more complex patients approached, with a multidisciplinary team with either remote or off-site ICU consult on the labor floor with ICU level nursing on site. ICU admission for low dose vasopressors and A-line, or even just monitoring because they're sick, which have all been described in studies, it's unnecessary and it has potential long-term implications for that mom and baby. I think as anesthesiologists, we should embrace our expertise in caring for critically ill patients in the main OR and on the labor floor and provide our services to the OB patients on the labor floor where we serve these patients best. I think, well, I have a lot of thoughts on this and it's not really relevant to this talk, but what I'll say is that taking a patient out of the unit where you have an anesthesia team that knows obstetric anesthesia, can manage a labor epidural, knows all the obstetric medications, dosing, routes of administration, and knows how to manage those patients with the obstetrician, taking the sickest patient out of that environment and putting them into one where we're great in the ICU at lots of things, but not obstetric anesthesia and not obstetric care, that's crazy. I think it's crazy to move them to a place where we don't care for obstetric patients. If they need like Velitri and a PA line, okay. But I think that this is the direction of the future is us as obstetric anesthesiologists flexing some critical care, appropriate critical care on the labor floor to keep our patients in the place that we take best care of them. I digress. Okay, so as we look for areas to improve, the studies show we're generally just slow to act. Delays in patient assessment, escalation, and management are major contributors to maternal morbidity and mortality. And getting those antibiotics in as soon as possible is so, so important. Of course, we want to be good stewards, but when it comes to these patients, every minute, every hour counts. And we have proven to be pretty bad at treating infection in pregnant women in a timely manner. So the Embrace study from 2023 has a really nice discussion. It highlights the need to provide critical care wherever pregnant patients are located. And it's highlighted by a quote that the value of having critical care co-located with maternity services cannot be overemphasized. In one woman who died, the physical distance between the critical care facilities resulted in considerable challenges in being able to respond to an obstetric emergency. So the answer is do not send them away to the ICU where their obstetric needs may not be anticipated or addressed in a timely manner. As obstetric anesthesiologists, I really think our role is incredibly valuable. Getting involved early and helping OB providers is super helpful. We recognize these sick patients so much better than any other physicians in the hospital. Physically examine these patients, use your tools like TTE, interpret the data through the lens of maternal early warning systems. I've printed out the algorithm from the CMQCC to discuss patients when I was worried, with the obstetrician to highlight that abnormal parameters were concerning and not just pregnancy related changes, and write for those antibiotics, whether there's a fever or not. If your suspicion is high enough for infection, just write for them. Help with additional IV access to ensure you aren't waiting hours for the second antibiotic to be infused. Advocate for your pharmacy to stock common antibiotics on the labor floor to reduce how much time you're waiting for those antibiotics. And do not let these women linger. This could save a life. All right, so this is one of my favorite talks. So I really appreciate that I was able to sneak in today because it's so important. This is such an important source of maternal morbidity. And I hope this has been helpful to you to highlight some key points that you can use and you are the experts on the labor floor for this. So, despite the increased awareness of maternal sepsis, morbidity is not decreasing. So we need to do better. It's really hard to diagnose these patients. So just be suspicious, act quickly, act collaboratively, and be thoughtful about offering regional, use shared decision making. It is not contraindicated and may certainly be the best anesthetic for our patients. That is all I have. It wasn't a whole hour. Okay. Then we have plenty of time to talk. So I will get out of here. There we go. I'll get out of here and get back into Zoom somehow. Maybe. And we can chat. Thank you guys.